Hey guys, so we'll continue this series of lecture on ECG, and as we have already discussed that interpretation of ECG will take these 11 things. It is rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, QT interval, T wave, U wave, and progression of R wave in ECG leads. Up till now we have discussed till QRS complex, so we'll continue our lecture with ST segment. So ST segment is again a isoelectric segment which represents ventricular repolarization. Okay, so ventricular repolarization is represented on ECG by ST segment and U wave. Okay, now ST segment, this portion is ST segment, and the abnormalities in ST segment can be ST segment elevation or ST segment depression. Now, what is ST segment elevation? Okay. In an ECG, the TP segment is the isoelectric segment, which is generally taken as the baseline. So we can say that any segment is elevated or depressed with respect to this TP segment, which is an isoelectric segment. Okay. Now, ST elevation, significant ST elevation is defined as ST elevation of more than 1 mm in two contiguous leads, except for leads V2 and V3. Since V2 and V3 are the most anterior leads and they are closest to the heart, so ST segment elevation in these have a different criteria. In V2 and V3, ST segment elevation should be more than equals to 1.5 mm in women, more than equals to 2 mm in males more than 40 years of age, and more than equals to 2.5 mm in males less than 40 years of age. Now, what are the DDs of ST elevation? ST elevation can occur in a variety of conditions. The most common being ST elevated MI, acute pericarditis, and we can have ST elevation in hypokalemia. We can have ST elevation in pneumothorax. Okay. Hypothermia, etc. Out of all these things, it is important for us to distinguish between STEMI and acute pericarditis. Now, how can we distinguish between STEMI and acute pericarditis? First of all, on the basis of history. The characteristic of chest pain in STEMI and in acute pericarditis is different. Also, the pain of acute pericarditis can radiate to trapezius. In STEMI, the pain doesn't relieve on bending forward, while the pain of acute pericarditis relieves on bending forward. The pain of STEMI is constricting, associated with sweating, and the feeling of impending doom, while the pain of acute pericarditis is sharp shooting and can be localized. Clear? Apart from these, on the basis of ECG, the ST elevation in STEMI, the ST elevation in the ST elevation in STEMI is like this. Well, the ST elevation in pericarditis is like this. This is convex upwards. is concave upwards. Also, the ST elevation in STEMI can be localized to a particular vessel. Like if there is involvement of RCA, we can have ST elevation in lead 2, 3 AVF. Or if there is involvement of LCX, then can be ST elevation in lead 1 AVL, V5, V6. While in acute pericarditis, ST elevation occurs in all leads except AVR and V1, which will be having ST depression. Okay. Again, in STEMI, we have reciprocal changes. Like if there is involvement of RCA or there is inferior wall MI, then we have reciprocal ST depressions in lateral leads, like 1 AVL, V5, V6, which is not the case in acute pericarditis. Also, we have PR segment depression in acute pericarditis. Okay. Also, TP segment is also depressed in acute pericarditis, which is known as spotting sign. Okay. Now, we shall discuss about how to localize STEMI, like which wall is involved or which vessel is involved. First of all, we'll discuss which wall is involved. As we have already discussed that this was lead 1, lead 2, lead 3, AVF, AVL, this was AVF. Since lead 2, 3, AVF are pointing downwards, so these are inferior wall leads. So there will be ST elevation in lead 2, 3, AVF in inferior wall. Lead 1 and AVL are lateral wall leads along with these V5 and V6, which are also lateral wall leads. So 1 AVL, V5, V6 will represent lateral wall. Then in YZ plane, we have lead V1 to V4, which represents anteroseptal wall. Out of these, V1 is septal, V2 to V3 is V2 to V4 is anterior. Okay. Now, suppose we have an ECG with ST elevation in lead 2, 3, AVR. We can call it as inferior wall MI. Yeah. Then we have ECG with ST elevation in lead 1 AVL, V5, V6, and we can call it as lateral wall MI. We have ST elevation in lead V1 to V4, and we can call it as anteroseptal wall. Posterior wall is not represented in a 12 lead ECG. We have V7 to V9 leads for posterior wall. Okay. So if we have ST elevation V7 to V9, then we can have posterior wall STEMI. Another way to identify a posterior wall STEMI is in posterior wall STEMI, there will be reciprocal ST depressions in V1 to V3 with upright T waves. So if we have this pattern along with the chest vein, then we can order a V7 to V9 leads, which may show elevation. Now, after localizing the wall, we have to localize the vessel. We have these vessels, LMCA, dividing into LAD, LCS. And LAD covers the most area, so it can be divided into proximal LAD, mid LAD, distal LAD. Okay. LCX, then we have RCA. Now, suppose we have ST elevation in 1 AVL, V5, V6. It's a lateral wall MI. The clear cut vessel involved is LCX. But if we have ST elevation in 2-3 AVF, then it's an inferior wall MI. The vessel can be involved as RCA or LCX because inferior wall can be supplied by both RCA and LCX. Okay, so in this scenario, we have to look at lead 2 and 3. If ST elevation in lead 2 is more than lead 3, that means LCX is involved. If ST elevation in lead 3 is more than lead 2, that means RCA. Now suppose there is ST elevation in lead V1 to V4. Its anterior septal is mostly associated with elevation in lead AVR, sorry. And the vessel mostly involved is LAD. In LAD, the ST elevation in V1 is more than ST elevation in AVR. Now, in proximal LAD, we can have reciprocal ST depression in 2-3 AVR. While in mid to distal LAD, we can have isoelectric 2-3 AVR. And in wraparound LAD, in some situation, LAD wraps around the inferior wall and supplies the inferior wall too. So in case of wraparound LAD, we have ST elevation in lead 2-3 AVF along with lead V1 to V4. Okay. Now the last vessel left is LMCA. In LMCA, we have ST elevation in lead AVR and V1 with ST elevation in AVR more than V1. Along with we have ST depressions and T-wave inversions in lead V2 to V6. Now ST depression. So ST depression of more than or equals to 0.5 mm in two continuous leads may indicate myocardial ischemia. So we have different causes of ST depressions like myocardial ischemia, and we can have reciprocal changes of a STEMI, and we can have digoxin effect, electrolytes, LVH with strain, or bundle branch block, or RVH with strain. Okay. QT interval. So QT interval includes QRS complex plus ST segment plus T wave. So it represents ventricular depolarization plus repolarization. And the QT interval changes in an ECG with heart rate. So ruling out this difficulty, we generally use corrected QT interval, that is QTC. We have different formulas for correcting the corrected QT interval. The most commonly used formula is Bassett formula, which states that QTC is equals to QT interval upon under root of RR interval. Okay. The cutoff is QTC of more than 0.45 seconds in male and more than 0.46 seconds in females is significant and is called as prolonged QT. Now, what is the difficulty with prolonged QT? Suppose someone is having a prolonged QT interval. So it generally represents that there is increase in relative repolarization phase. Now, since there is increase in the relative repolarization phase, it can increase the chance of arrhythmia. So at this point, if any delayed after depolarization comes from upward, then can begin a re-entry circuit, which can lead to polymorphic VT, which is also known as Torsades 3 point. Clear? Now, what are the causes of prolonged QT? Can be divided as congenital or acquired. In congenital, we have long QT syndromes like LQT1, 2, 3, up to 17, 18. Okay. In acquired causes, we have electrolytes. In electrolytes, we have hypomagnesemia, hypokalemia, hypocalcemia. Then we can have drugs. Then we can have infections, which can cause prolonged QT. Clear? T waves. So T waves represent repolarization of the ventricles, and the abnormalities in T waves can be tall T waves or inverted T waves. Tall T waves can be defined as more than 5 mm in limb leads or more than 10 mm in chest leads, or they can be defined as more than half of amplitude of QRS. Okay. Now, what are the causes of tall T waves? So the two major causes of tall T waves are: one is hyperkalemia, another one is hyperacute MI, which can lead to winter T waves. In hyperkalemia, the T waves are called as tall tented T waves. This is suppose T wave of hyperkalemia, so it will be pointed at the end. It will be symmetrical and definitely tall. T wave inversions. T wave inversions can be there in ischemia, in strain, and can sometimes be seen normally. In lead AVR and in lead V1, generally we have inverted T waves. Again, the next thing that we have to look for is progression of R wave in chest leads. So have to look for progression of R wave from lead V1 to lead V6. The transition from S wave to R wave generally occur in lead V3 and V4. So in lead V1, we generally have this small R wave and a big S wave, while in V6, we have a small Q wave and a big R wave. Okay. The transition generally occurs in V3 and V4, where we have almost equal R and S wave. Now, what are the causes of poor progression of R waves? Poor progression of R waves can be seen in emphysema, as we will be having a tubular heart, as lungs will become hyper expanded. Then we can have in all MI in left anterior fasciculum. The last thing that we have to look for in an ECG is a U wave. The U wave can be because of delayed depolarization of the Purkinje fibers, or can be because of prolonged repolarization of mid-myocardial M cells. These are different hypotheses for a U wave, and U wave is generally looked for in lead V2 and V3. Okay. The normal U wave is less than 0.2 mm and is generally seen when there is bradycardia or heart rate is less than 65. Okay. Now, what is a significant U wave? When the U wave is more than 0.2 mm, and it can be seen in severe bradycardia or hypokalemia. Yeah. So we end our lecture on this note, and we will have further discussions on different ECGs. So I'll take some ECGs and we'll discuss on that. Thank you very much.